I have the privilege of inviting Dr. Takeshi Sano from Japan. He's a very eminent surgeon, famous for D2 gastrectomy, and a lot of people here in Calcutta had the honor of watching him doing D2 gastrectomy. The video has been shown with his permission in different forums. And we know the Japanese are very good in doing D2 gastrectomy. They rely more on the surgical technique rather than the adjuvant treatment. But it would be interesting to hear from the surgeon himself about the multimodality treatment in CS stomach.
Hello, good morning, ladies and gentlemen. Thank you very much for your kind invitation and remarks. And I'm very happy to be able to come back to this beautiful city and to see your amazing driving technique in the city, although it is a bit too thrilling and too noisy from Tokyo driver's viewpoint. Today I'd like to talk about the treatment of gastric cancer in multimodality setting. But before talking, I'd like to confirm one thing. This is a global consensus that is surgery is essential for cure of gastric cancer. Okay? No surgery, no cure. And sometimes, of course, we may experience a pathological complete response by chemotherapy or chemoradiotherapy, but we cannot confirm that without surgery. So when you plan treatment for potentially curable gastric cancer patients, you should always consider the surgery as a core, and you should consider when and how you perform surgery. But in potentially non-curable, or not potentially, but apparently non-curable gastric cancer, surgery should be limited to urgent symptomatic relief only. So I'd like to talk about this potentially curable gastric cancer in my talk. And for a senior surgeon like me, gastric cancer, small t1, is just like too easy. Endoscopy may cure, or even resident surgery is sufficient. But for a bit more advanced one, T2, T3, with some lymph node metastasis, this is the real target of surgery, but still it's easily curable, resectable tumors. But when the tumor invades the adjacent organs or with association with bulky lymph node metastasis, then it is the marginally resectable gastric cancer, and we have to fight against this disease seriously with multimodal treatment. And further development, then it's too late for us surgeons. So these two easily or marginally resectable gastric cancers are the real target of multimodal treatment. So the resectable gastric cancer that may or that will recur, we need some strategy. This is a combination of surgery and chemotherapy and or chemoradiotherapy, and there are various combinations. Usually surgery first, followed by chemotherapy or chemoradiotherapy, but recently we are talking about the neoadjuvant chemotherapy or chemoradiotherapy. And as for adjuvant or neoadjuvant randomized controlled trials for gastric cancer, we had a very dark period for a long time, but finally we enter the new era of adjuvant therapy for gastric cancer. We have three different modalities, effective modalities in three different regions. First paper was from the United States, intergroup 0116, in the post-operative chemoradiation, and then the MAGIC trial from Europe, and finally the IASGCON post-operative single-agent chemotherapy from Japan. All these three trials are large-scale randomized control trial with surgery alone as a control arm. And let me briefly review these three trials. First, American intergroup study, they targeted is the adjuvant chemotherapy, the patients with curable resection from American point of view. They randomized them into the surgery alone or surgery followed by chemoradiation therapy. And they showed the survival benefit of chemoradiation therapy in overall survival. And there are some interesting subset analysis. For intestinal type tumors, the survival benefit is large by chemoradiation therapy, but for diffuse type tumors, interestingly, patients with chemoradiation group show the worst survival. And when the surgery is D0, simple gastrectomy without systematic dissection, then the benefit is large, and D1 is same. But if you perform D2 dissection, although the number is very small, the survival benefit of radiation therapy is unclear. And the intergroup study, they recently showed the long-term results. Even after 10 years of follow-up, this difference continues, and they show the survival benefit of chemoradiation therapy. And these interesting subset analysis. The center line is the hazard ratio 1, and the right side is the better tendency, and almost all subsets shows the better favorable results from chemoradiation therapy, but for female there was no benefit, and for diffuse tumors no benefit, and in combination female with diffuse tumors showed significantly worse survival by chemoradiation therapy. This is very interesting, probably because most of these tumors may have already free cancer cells in the peritoneum which was not detected or which cannot be controlled by chemoradiation. So we interpret this study that adjuvant chemoradiotherapy is effective on residual local disease after limited surgery. So we don't know whether this radiation therapy is effective after complete D2 dissection. And the MAGIC study from Europe, they recruited the patients with probably resectable tumors, and they randomized them into either immediate surgery or perioperative chemotherapy group. And they showed beautiful difference of benefit of this new perioperative chemotherapy. And the researchers should be congratulated, but actually there are several important problems in this study, and I have no time to discuss each one, but simply I'll show you that the surgery was performed and many patients had non-curative surgery. That is, the surgery alone group, 30% of patients have already non-curable factors which was found in the surgery. And also, when the patients had relapse, in surgery alone group, majority of patients could not receive any chemotherapy at all. So we interpret this trial that neoadjuvant ECF may prolong survival of patients who may have non-curative factors or in a circumstance where chemotherapy is not available after relapse. And our IASGCON trial in Japan, we recruited the patients after complete curative D2, strictly D2 gastrectomy, and intraoperative peritoneal cytology must be negative. Then we randomized patients into the surgery alone or adjuvant oral S1 for a year. We recruited 1,000 patients, and we showed the survival benefit of this 5-year follow-up. And if we compare all these three survival curves in the same scale, the white lines are the surgery alone curves. MAGIC show the worst survival curve because they have a lot of non-curative patients, and our Japanese patients show by far the better survival by surgery alone because we very carefully selected the patients. Let me compare three studies. The intergroup study and MAGIC and IASGCON, and we have 1,000 patients, and all these trials, the results are published in the New England Journal of Medicine, and the Japanese patients, interestingly, have the oldest median age, and male gender was the majority in MAGIC trial because they recruited also the lower esophageal adenocarcinoma, which is predominantly the male disease. And curability is high in intergroup study and Japanese study, but 30% of patients were non-curative in the surgery group in MAGIC trial. And the tumors, T4A, T4B proportion was lowest in Japan, but the pathological node positive proportion was the highest in Japanese series. And peritoneal cytology was strictly negative in Japanese studies, but it was not applicable in other two studies. And the tumor location is mainly in the distal part, and in the United States study and Japanese study, nearly 60% of patients underwent distal gastrectomy, but the MAGIC trial required total gastrectomy in majority. And in Japanese study, D2 was performed in 100%, intergroup study only 10%, and MAGIC trial, this is 66%, but I don't believe this, because in the first presentation they didn't show any data of this, and only in the New England Journal paper they suddenly show the D1, D2 by their own definition, extended or limited, and I cannot believe this, because in this MAGIC study, the D1, D2 trial of Netherlands and also MRC trial was open, and they knew that D2 is very dangerous with 13% operative mortality. So this 60% of D2 is I can't believe this. And anyway, the survival is a big difference, and interestingly, in each study, the hazard ratio of this, each treatment method is very similar. So the curability is the highest in Japan, by far the lowest in MAGIC study, and tumor stage is earlier in Japan, and local control is better in Japan, and therapeutic power is similar among three studies. This is very interesting. So if you look at these three studies' survival curves, now you know that we were treating different patients with different methods, and according to the situation, each treatment can propose some survival benefit. So you should choose. You should not simply compare all these studies, but you should choose which you are working, which circumstances you are working, and which patients you are treating. So the tactics for easily resectable gastric cancer, we propose that surgery first. We can get the sufficient resection margin by D2 lymphadenectomy, and according to the pathological stage, we can decide the follow-up, the adjuvant chemotherapy. If the tumor is pathological stage 1B or 2A, or very easy, we may even observe the patients without adjuvant chemotherapy. And in Japan, we choose S1. In Korea, after classic trial, they choose Xelox. But anyway, we should develop more effective adjuvant therapy and identify high-risk cases by pathological stage. But for marginally resectable gastric cancer, multimodal therapy is mandatory, and downsized by neoadjuvant chemotherapy and adequate surgery and consolidation by adjuvant therapy, these should be well designed. And in order to do this, we should develop sharp neoadjuvant therapy and establish optimal lymphadenectomy. In Japan, we are now shifting very slowly from adjuvant setting to neoadjuvant setting, and the target is two types of tumors. One is this large ulcerative cancer or linearis plastica. These can be removed, potentially curable resection is possible, but still the prognosis is very poor. And with these tumors, we have conducted a randomized neoadjuvant study. Just finished recruitment. We'll wait for the final results. This is S1 and cisplatinum is the Japanese standard for neoadjuvant treatment. The other category is the bulky nodal metastasis without peritoneal disease. So we define these bulky N2 or N3 lymph nodes, and we perform the staging laparoscopy to confirm no peritoneal disease, and then we give neoadjuvant chemotherapy and performed very extended super D3 dissection. And this is the first trial of phase 2, CPT11 and cisplatin followed by D3 was tested, and the 3-year survival was better than historical control, but it's not yet not satisfying. And this survival curve is very similar to the MAGIC trial curve. But we tried S1 cisplatinum followed by D3, and amazingly, the 3-year survival exceeded nearly 60%, and this was beyond our expectation. And now we are trying more effective S1 cisplatin docetaxel followed by D3. And this is a phase 2 study. We have just completed the recruitment, and we'll wait for the results. But anyway, we are slowing, shifting from postoperative adjuvant to neoadjuvant to selecting these high-risk patients. And now in the world, there are various adjuvant, neoadjuvant chemotherapy going on, and in the coming years, you will see various settings, but you should be careful. These are not the new drugs treatment for non-resectable tumors. These are adjuvant or neoadjuvant, and the role of surgery is very important. So, ladies and gentlemen, in conclusion, T2, T4 resectable gastric cancer should be treated with multimodal therapy, definitely. An adequate combination of surgery and chemoradiotherapy is the key multimodal therapy, and selection of modalities depends on not only tumor or patient's condition, but also the surgical circumstances. Thank you for your attention.